So in this part, we are going to discuss about the bacterial hypersensitivity mediated corneal disease. So basically, it is a antigen antibody interaction, antigen plus antibody. So when there is this is an immune mediated response of any disease, and when it causes the corneal disease, it causes the bacterial hypersensitivity mediated corneal disease. So we include marginal keratitis and phallic tannulosis in this um, series. Marginal keratitis introduction. Marginal keratitis is believed to be caused by a hypersensitivity reaction against a staphylococcal exotoxin and a cell wall protein with deposition of the antigen antibody complexes in the peripheral cornea. Antigen diffusing from the tear film, antibody from the blood vessel, with a secondary lymphocytic infiltration. The lesions are culture negative, but Staph aureus can be frequently be associated isolated from the lid margin. So there is a lot of information in there. So basically, as we know that the staphylococcus have an exotoxin. So the patient uh, produce a hypersensitivity to this exotoxin and its cell wall protein. And what happen is when there is an antigen, so that these antigen antibody complexes become deposited in the corneal periphery, and when this is deposited there is a secondary lymphocytic infiltration with it, which causes the marginal keratitis. The lesion itself is not is culture negative for Staph aureus, but the lid margin does have the Staph aureus in it. So how are the diagnosis is made? Mild discomfort, redness and lacrimation. The inflammation may involve both eyes. So it can be bilateral as well. Chronic blepharitis is typical. So whenever the patient is blepharitis and you can see an ulcer in the periphery, you always think of a marginal keratitis. Chronic blepharitis is typical. Inferior punctate epitheliopathy is an early manifestation. So it usually affect with the blepharitis, and there will be the inferior keratitis. So inferior punctate epitheliopathy is going to be the early manifestation. Subepithelial marginal infiltrate separated from the limbus by a clear zone, often associated with an adjacent area of the conjunctival hyperemia. So we are going to see the figure 7.26a and b for that. So marginal keratitis A and B, marginal infiltrates. So what can you see here? That there is an area of infiltration, and there is a conjunctival hyperemia with it, and there is some but clear zone of the limbus. Subepithelial marginal infiltrate separated from the limbus by a clear zone, often associated with an adjacent area of conjunctival hyperemia. Characteristically, any epithelial defect will be considerably smaller than an area of infiltrate. So basically, the area of infiltrate is greater, and there can be an epithelial defect, but that is very minor as compared to the infiltration. Coalescence and the circumferential spread. So it spread, and so there are multiple lesions that will coalesce and that will spread circumferentially. Usually little or no anterior chamber reaction even with large infiltrate. Without treatment, resolution generally occur in 1 to 4 weeks depending on the severity. Occasionally there is a residual superficial scarring and slight thinning with the mild painless. Iris new vessels may develop in the presence of the large persistent large lesion but resolve when the inflammation settles. So this is very important, that iris new vessels can be developed in this case, and its mechanism is not known. And the thing is that it is going to if there is no treatment, the lesion can resolve on its own. So what are the treatment for this? So basically the treatment is, as we know, is it is an immune mediated. So whenever there is an immune mediated disease, we always think of steroid. whether or not there is an epithelial defect. A weak topical steroid such as an FML, fluoromethanol, or prednisolone 0.5% instilled 4 times daily for 1 to 2 weeks. Sometimes combined with topical antibiotic and oral tetracycline course, erythromycin in children, breastfeeding and mothers and in pregnancy may be required for a recurrent disease prophylaxis is treated as necessary. So we in the mainstay of treatment is topical anti steroid or plus minus antibiotic, and oral tetracycline is given because it has an anticollagenase effect. So we can see figure 7.26, marginal keratitis A and B is showing the marginal infiltrate, C is showing coalescing infiltrate, and D is showing the mild scarring and a penis formation. So this is a penis formation. Now next is phyllectanulosis. Introduction. Phyllectanulosis is usually a self-limiting disease but may rarely be very severe. Most cases in developed countries are the result of a presumed delayed hypersensitivity reaction to the staphylococcal antigen, sometimes associated with rosacea. In developing countries, the majority are associated with tuberculosis or helminthic infestation, but causation may be uncertain and a range of other agents has been implicated. So basically, it is also an delayed hypersensitivity reaction. It is a type 4 hypersensitivity reaction, usually to the staphylococcal antigen in the developed countries and helminthic and TB in the undeveloping countries. So, what are the diagnoses? Diagnoses are photophobia, lacrimation, and blepharospasm, often in child or young adults. So, the patient complain of sensitivity to light, increased tear production, and blepharospasm is in contractions of the eyelid. Signs are a small white limbal band or conjunctival nodule associated with the local hyperemia. So one thing with the phyllectanulosis is you should always remember is a nodule. There can be a conjunctival or a corneal nodule in this case, and this is going to be limbal. A white small limbal or conjunctival nodule associated with the intense local hyperemia. A limbal phyllectan may extend into the cornea. Spontaneously, resolution occur within 2 to 3 weeks. A healed lesion often leaves a triangle limbal based scar associated with superficial vascularization and thickening, but occasionally severe thinning and perforation can ensue. Very large necrotizing or multiple medullary lesion may occur. So we can figure 7.27a and m. So it is showing a phyllectanulosis, a limbal phyllectan with an inflamed eye. So I think this is showing the inflammation, and I cannot see the inflamed. I think here it is in phyllectan. B is showing the phyllectan in a relatively quiet eye. So this is a phyllectan and it is a relative quiet eye. C is showing the corneal phyllectan. D is showing the corneal phyllectan with intense vascularization. So, investigation for tuberculosis is generally indicated only in endemic areas or in presence of a specific risk factors. So, we do investigation for TB in this case. Treatment. A short course of topical steroid accelerate healing and is often given with topical antibiotic. Recurrent troublesome disease may require oral tetracycline and is important to treat associated blepharitis. So, its treatment is the same as a case of a marginal keratitis. Now, as the rosacea is associated with the phyllectanulosis, so we are going to study it here now. Rosacea. So, rosacea is basically, you can say, a skin condition. Skin condition in which there is a large acne formation on the face and red papule formation, and the patient complain of blepharitis. It can complain of phyllectanulosis. So let's study. Rosacea interaction. Rosacea, acne rosacea is a common chronic idiopathic dermatosis involving the sun-exposed skin of the face and the upper neck. Ocular complications develop in 6 to 18% of the patient. Facial telangiectasia, papule and pustule formation, rhinophyma, and facial flushing may occur. Figure 7.28. In contrast to acne vulgaris, comedones, blackheads or whiteheads are absent. So there are no whiteheads and blackheads. So let's see figure 7.28. So you can see that there is a flushing of the skin of the sun exposed area, and there is a papule formation, and there is uh, a rhinophyma. The etiology is probably multifactorial and may involve vascular factor together with an abnormal response to commensal skin bacteria and Demodex follicular mite. Exacerbation by the H. pylori infection has been uh, suspected. So basically, this skin condition is abnormal response to the normal skin bacteria, especially Demodex follicular mites. Ocular rosacea. So what are the ocular rosacea is how the rosacea involve the cornea. So one thing to always remember with rosacea is a telangiectasia. Telangiectasia is the dilated uh, capillaries or blood vessels that is present on the um, on anything. So telangiectasia is that. So telangiectasia is very associated with rosacea. Symptoms include non-specific irritation and lacrimation. Lid signs include margin telangiectasias and posterior blepharitis, often associated with recurrent Meibomian cyst formation. So let's start with the lid. So lid you always remember with blepharitis plus telangiectasia. So let's see figure 7.29a. You can see that there are dilated blood vessels on the lid margin. Next is conjunctiva. Conjunctival hyperemia, especially bulbar, rarely see contritial conjunctivitis, conjunctival granuloma, and phylactenulosis may occur. So one thing very important you should always remember is phylactenulosis associated with rosacea. Now next is a corneal involvement. Inferior punctate epithelial erosion, peripheral vascularization, marginal keratitis, focal or diffuse corneal thinning, usually inferiorly in severe cases. Perforation may occur as a result of a severe peripheral or corneal melting, may be precipitated by secondary bacterial infection, corneal scarring, and vascularization. So these are all the corneal manifestations that can occur with the rosacea, but remember that always there will always be some kind of the skin lesion that would be present with the rosacea. You will diagnose a condition of rosacea, ocular rosacea, with the skin condition. So there can be epithelial erosions, there can be marginal keratitis, there can be phylactenulosis, there can be the corneal thinning, perforation, scarring, and vascularization. So let's see figure 7.29 C and D. So A is showing the eyelid marginal telangiectasia, B is showing peripheral corneal vascularization, C is showing the focal corneal thinning, D is showing the severe scarring and vascularization. So what are the treatment of ocular rosacea? We are going to give the lubricants, preferably be unpreserved for mild symptoms, hot compresses, and lid hygiene. So these are generally the symptomatic treatment. Topical antibiotic, for example, fusidic acid, erythromycin, azithromycin to the lid margin at bedtimes for 4 weeks. So we have to treat the, basically it does a reaction to the bacteria or normally found bacterial, so we can give topical antibiotic. Steroids are helpful for exacerbation. The lowest potency preparation compatible with improvement should be used in order to minimize the promotion of thinning. So we use topical steroid, but with very cautiously, because it can induce thinning in this case of rosacea. Systemic therapy. Tetracycline may work by altering meibomian gland function to lower free fatty acid production in conjunction with the reduction in lid flora and probably by direct anti-inflammatory effect. They also have an anti-collagenase action and so may retard thinning. What are the role of tetracycline? It have an antibacterial effect. It have bacterial effect. Number 2, it has anti-inflammatory effect, and number 3, it has an anti-collagenase effect. So they retard thing in relatively low dose but extended duration. For example, doxycycline, which has a longer half-life than tetracycline, 100 mg once daily for 4 weeks, then 50 mg if daily if required. They may confer an improvement lasting several months, but if necessary can be continued long term. Tetracycline should not be used in children and pregnant or breastfeeding women in whom erythromycin is an alternative. So whenever there is a case of breastfeeding children or women, pregnant women, we give erythromycin. Efficacy has also been reported with other antibiotics. Severe diseases may require immunosuppression, for example, azathioprine. Retinoids can be helpful but can worsen some features. They are absolutely contraindicated in pregnancy. So that's it for the cornea part 12. Thank you very much.